Fulfilling financial duties. The National Foundation for Trauma Care states, trauma care is not charity care. Knowing payer mix is better for reimbursement. Trauma patients can be more challenging and more resource consumptive. Trauma surgeons have higher levels of requirements than other general medical staff in responding to trauma team activations. Payment is deserved and should be pursued, and a cost center for trauma patients should be determined and contained within revolving fiscal performance improvement. Additional reasons for charging this fee. The hospital should receive some reimbursement for the costs of managing a trauma program, since patients ultimately benefit from these services. Trauma patients receive an intensive level of evaluation and treatment, which requires hospitals to expend higher levels of resources in order to manage their care. Emergency department services alone do not cover the extra costs associated with the treatment of the trauma patient. Because of this program's infrastructure, it costs the trauma center more to care for trauma patients than it does for a non-trauma center. It is reasonable and fiscally prudent to seek reimbursement for costs incurred. Cost centers for trauma programs need to be established and closely monitored to continue to demonstrate the financial viability of your program. In this economic climate and with ever-changing healthcare structures, you must be able to show your program pays for itself. You must know what is going out of your program, the costs, what is coming into your program, reimbursement, and what the program balance is. This can be challenging. It's all a matter of balance. Only facilities that have been state designated or are ACS verified may bill for trauma team activation. All designated and verified facilities should be working to develop and charge a fee for trauma team activation. You work hard for these patients, so you should expect reimbursement for the care and resources expended in taking care of them. Unfortunately, no set fee structure for trauma team activation billing exists, so each facility must develop its own fees. Involving fiscal staff who understand other fee development and implementation, the government rules and guidelines associated with those, and billing requirements is essential in developing charges that will stand up to auditing as to how your facility developed its fee. Requirements for charging the trauma response fee are below. Your facility must have an organized and identifiable team, and there must be written criteria for trauma team activation implementation. It must be documented that the trauma team was activated, for what level and at what time, preferably on the trauma flow sheet. You can only charge this fee for eligible patients. The trauma patient needs to be determined to need trauma team response and ED care based on pre-arrival information provided by EMS, or a patient transferred to your facility also needing trauma team activation for definitive care that other facilities cannot provide. For example, a motor vehicle crash patient in Superior who sustains injuries they are unable to definitively manage is transferred to St. Patrick Hospital in Missoula for operative care. In this case, both facilities activated their trauma teams based on their criteria, and both may bill for it. Other trauma team activations eligible for trauma fee billing are below. These must meet earlier fee criteria and be brought in by EMS. ED to ED interfacility transfers, or physician referral from clinics, etc. Always review and update trauma team activation criteria, policies, guidelines, and procedures. Meet the needs of the trauma patient and your facility. You need to document the level of team activation, so let's discuss those levels now. A full trauma team activation, the highest level, means that a surgeon is present upon patient arrival and all identified trauma team members are present. These include an ED physician, ED nurses, EMS, RT, lab, X-ray CT and the OR crew, anesthesiologist, scribe, and any additional team members. Partial trauma team activation can happen two ways. Either when an ED physician responds initially and a surgeon arrives later within a certain time period, or the list of trauma team members is modified. Note that these situations do constitute a full activation for facilities without a surgeon or operating room. In these cases, a trauma consult needs to occur within 3 to 24 hours of patient arrival by the surgeon. Here is an example of the trauma response codes to use, depending on trauma center designation. 068X trauma response charge levels for trauma team activation and the related definitions can be found in the Medicare Claims Processing Manual, which is in the Resources section of this module. Patients who arrive by private vehicle, police, walk into the ED, or arrive by any means other than EMS are not eligible for the trauma team activation fee. There is national discussion about developing a reimbursement code for these trauma patients, though, for whom the trauma team is activated. We know these trauma patients can sustain injuries as significant as those who arrive by EMS and may utilize the same increased levels of resources, evaluation, and treatment. Additionally, patients who do arrive by some form of EMS but there was insufficient pre-notification to activate the trauma team are not eligible for the fee billing either. To set up a trauma service cost center, these steps should be followed. Evaluate and refine your list of charges. 2. Automate the method for allocation of charges. This allows for automated coding and charge allocation and can even cue the provider for more complete documentation. Okay, we can dream. This also means being aware of new trauma revenue codes to better document the hospital status as a trauma center and the services rendered. 3. Evaluate and adjust your patient account documentation process. 4. Evaluate your entire billing and collection process, provide education, implement process performance improvement, and enhance staff resources to optimize account collection. Step 5 is to know your payers and who pays. For example, auto insurance, homeowners insurance, victims of crime, and Indian Health Services, and then know the rules for each. Step 6, don't give it away in the contract. Don't give one-way, payer favorable, or vague contracts. All patients are registered as a type of patient, emergent, urgent, elective, or newborn. Once a facility is trauma designated or verified, the facility may then register an additional patient type, trauma center. Registration, admitting, and HUC staff must be able to utilize trauma center as a patient type for those patients who receive a trauma team activation. This provides the ability to easily track these patients in many ways and allows for ease and continuity of billing. Additionally, since trauma patients not arriving by EMS may receive a trauma team activation but can't be billed for it, you may want to implement an additional area where the registration person can indicate this situation, as seen here. Budget for the trauma program should include the average number of annual activations and the estimated cost per activation, staff time, FTE, and salaries, equipment, trauma team activation and call-in costs, any physician response, call, and/or contract fees, and costs associated with ACS site surveys. The reimbursement generated from trauma response fees should be reconciled back into the trauma program budget and not into the general fund of a facility. Eventually, an important goal for the trauma program is to pay for itself with reimbursement funds acquired through trauma team activation and other related fees. If the trauma program employs PAs and/or NPs, their charges should also register as trauma program income.